We are recording this session for documentation, so please let us know by chat in case if you'd not like to be quoted, etc. In the interest of active consent seeking, I'd request anyone who is carrying an AI note taker to ask with the group, but I don't see one right now, so that's all right. For saving bandwidth, just keep your cameras turned off till the time you're speaking. We can all speak Hindi and English, so please feel free when you're asking a question to speak both in English or Hindi, whatever's preferable. We'll be able to also provide translation and transcription for people live in the comments. There is a chat box for you to leave your comments and questions. Please use that liberally, and we really request for you to not interrupt speakers as they're talking, and leave your comments in the comment section. And finally, one last thing, and it's just that we are deeply grateful for all of you who could be here. This is a really difficult time for so many of us in the country. There's several sort of mishaps that are already happening. There's a bunch of pressures that we're already dealing with, not just at work, but also at home. We are deeply grateful for all the panelists who could join us for this conversation, and we request for you to exercise patience and respect for everyone who's here. We want to create a safe learning environment, and please be mindful of that. Thank you. With that, I'll just quickly talk you through what's happening today. For this session, we're going to be talking about vaccines, vaccines efficacy, hesitancy, and so on. We have 20 minutes of context setting that we'll begin with just shortly. And then we have an esteemed panel who will go through some of the questions that are directed to them, and then an open open slot for questions and discussion. Before I begin, just a little bit about CoreNet. So CoreNet is a community of practice that was set up sometime in May 2020. And it really came as a response to the crisis as it began to erupt in the country. And we saw that several research efforts were happening in parallel to each other, trying to understand the many impacts of the pandemic on India. And the intention of the network was to foster exchange and collaboration. So far, in the past few months, the network now slowly has about 60 working organizations, about 200 members on a Slack workspace where we convene, and about 80 projects that are submitted on the web platform, which you can see. So www.corenet.in is like a web repository that you can have access to. Also, every week we've been doing these coffee hour sessions. These are also available for you to view on YouTube. And now that a year has passed, we wanted to bring the community together to discuss learnings from the past year and think about what would be the best ways to move forward. When we were planning this conference about 3 months ago, we didn't know that we will come at a time where, again, we're not really in a phase of recovery, but back to pandemic response. But we still felt like it's worthwhile to have these conversations to really figure out what are the most urgent steps to take as we move forward. With that, I would like to, actually just introduce our panel very briefly and then pass it on to the researchers who will do the context setting. We're really grateful to have Professor Rajib Dasgupta, who's at the Center for Social Medicine and Community Health at JNU. He served for a decade with Public Health Services at the Municipal Corporation of Delhi before joining the JNU in 2003. He's closely engaged with the National Health Mission, the Indian Council of Medical Research, and the WHO CRO in policy formulation as well as program evaluation activities. Then we have Dr. Farzana Islam. Dr. Islam is a community medicine doctor, is the professor and head at the Department of Community Medicine at the Hamdard Institute of Medical Research in New Delhi. She's an academic, researcher, and public health expert with more than 16 years of experience working on academic and research institutions such as WHO, UNICEF, NHM, and also in the areas of immunization, maternal health, health policy, disease surveillance, monitoring, evaluation. And she's led all COVID-19 activities, including vaccination for the Department of Community Medicine. Then we have Dr. Brighu Kapuria. Welcome, Dr. Kapuria. Dr. Kapuria is a medical doctor and a public health specialist by qualification. He specializes in the domains of immunization, reproductive and sexual health, HIV/AIDS, and has also worked at grassroots level to national program management during his 19-year career. He's currently the health specialist for immunization at UNICEF India and is engaged in planning and implementing strategic support from the UNICEF in key priority areas under immunization. Dr. Raj Ghosh is the senior advisor for vaccine delivery at the BMGF. Dr. Ghosh is a public health physician with over 30 years of experience in primary healthcare and infectious diseases. His primary interest is infectious diseases and vaccine delivery, so very, very relevant for what we're going to speak about today. And he also served as a regional coordinator for the National Polio Surveillance Project of the WHO in India. With that, I will briefly introduce the panelists who are going to be doing the context setting for today. So representing NCAER, we have Santanu Pramanik, who's a senior fellow at NCAER and also the deputy director for the National Data Innovation Center. He's a statistician and a survey methodologist by training. Joining him from Prayogshala is Anirudh Tagat, who completed his MSc in sociology from the University of Warwick. His research interests lie in intra-household bargaining dynamics, experiential game theory, and cultural analysis for decision making. And finally, we have from faculty Nanditha Kalidoss. Nanditha is a health fellow for Misinformation at faculty, and she holds a master's of public policy from the NLS, National Law School, University of India, and a bachelor's in media studies. With that, I would like to now pass on the mic to Shantanu to walk us through the context setting. Over to Shantanu.
Yeah, so thank you, Rohan, and I'd like to join Rohan in welcoming all of you, the panelists and the participants for today's discussion. And I sincerely hope that all of us remain safe and healthy during these difficult times. Thank you for being here. Okay, so let me start with just to give you some background that may help in continuing the discussion today. And I mean, most of you were aware of this, but just to put things together, it might help. So as you know that on 3rd January 2021, that's the beginning of this year, our regulatory authority has approved 2 COVID vaccines for emergency use. One is a variant of the vaccine made by AstraZeneca and Oxford University, which is known as Covishield in India and manufactured by the Serum Institute. And the other one developed by Bharat Biotech in collaboration with ICMR and the National Institute of Virology, Pune, and that is known as Covaxin. And starting 16th Jan, we started the massive vaccination rollout, starting with the health workers and the frontline workers. That's the phase 1 of vaccination. And during that time, we have vaccinated little over 11 million health workers and frontline workers till 28th Feb against a target of 30 million. So if you see the coverage rate, which is below the optimal coverage one can think of, and also given our experience with the childhood vaccination, where we have for most vaccines, we have coverage around 80% or even higher. Whereas in this case, it's below 50% that we achieved in the first phase. I mean, of course, adult vaccine is a completely different ballgame when compared to childhood vaccination. There are a lot of opinions and thoughts come into play, which are usually doesn't come into play and in the context of childhood vaccination. And also those vaccines are also very time tested and so on. So, I mean, there are many reasons behind that. And then in starting March 1, we have included the age group 60 years and above and over 45 years with comorbidities, and then relax the age group to include all people above 45 years of age. And then starting tomorrow, we hope to vaccinate all the adults above 18 years of age. So just briefly, that vaccine efficacy is the key in any vaccine approval process. And I mean, by efficacy, we mean the percentage reduction in disease between participants who were vaccinated and the group that didn't receive the vaccine. So one thing I just want to highlight that this efficacy can be assessed against different endpoints. Okay, it can be just the infection as picked up by RT-PCR test, or the severity of the disease requiring hospital and ICU admission, death from the disease, and also transmission of infection, whether it can prevent transmission or not. So that's the problem. I mean, given the way the clinical trials have been happening with less time, less follow-up of patients, so we are not being able to look at all the endpoints which are perhaps more critical. Only thing we, and most of the clinical trials that looked at is the infection. And just another point I want to highlight that vaccine efficacy does not always predict vaccine effectiveness in a real life scenario where the vaccine is administered in a non-randomly set up under field conditions. Usually vaccine effectiveness is lower than the vaccine efficacy of these two vaccines. Okay, so the first one, Covishield, that's the sister vaccine that's developed from the same cellular material that was used to develop the AstraZeneca and the Oxford vaccine. So for that, we had data from 4 randomized controlled trials from UK, Brazil, and South Africa. And the interim efficacy analysis based on more than 11,000 participants from UK and Brazil, but no data from India. Okay. But this is a sister vaccine of AstraZeneca and Oxford vaccine. So that interim efficacy analysis suggests 70% overall efficacy of that vaccine. So we can assume that the similar efficacy would hold true for Covishield because it's the same vaccine, same material, cellular material was used to develop the vaccine by Serum Institute. On the other hand, for Covaxin, we actually didn't have any efficacy data at the time of approval. So Bharat Biotech undertook a very large phase 3 clinical trials involving 26,000 participants across 26 sites in India to assess the safety, immunogenicity, and efficacy of Covaxin. But at the time of the approval process, these data was not available because the phase 3 clinical trial started only in mid-November. So in Jan, we didn't have any data at the time. What we had is that from data from phase 2 trial, which found tolerable safety outcomes and enhanced immune responses based on 380 participants. But as we know that phase 2 trial do not permit efficacy assessment. So basically we can say that the approval was based on the strength of safety and immunogenicity data alone for Covaxin. I mean, by now we know that an interim analysis suggests 81% efficacy for Covaxin as well. But at the time of approval, we didn't have any efficacy data for Covaxin. So now, where do we stand in terms of vaccine hesitancy? I mean, does that lead to vaccine hesitancy, or in general, where do we stand in terms of vaccine hesitancy? Yeah, so if we look at this graph, so this is from the COVID-19 symptom survey data. We have used data from, so COVID-19 symptom survey, it's an online web survey being conducted over 200 countries and over 50 languages across the world. India is one of the countries. And the Facebook user base is considered as the sampling frame for the survey. Okay, and the vaccine hesitancy question were included in the survey from 21st December. So we have used data from 21st December till date to come up with this estimate of vaccine hesitancy. And the hesitancy is defined as defined based on probably not and definitely not responses to the question. If a vaccine to prevent COVID-19 were offered to you today, would you choose to get vaccinated? If the respondents say probably not and definitely not, those have been considered to define hesitancy. So here you see, in general, the hesitancy level is quite high with Kerala, Odisha, Chhattisgarh are doing better. The hesitancy is around 20%, whereas states like Punjab, Tamil Nadu, etc., have a hesitancy of around 40%. So which is pretty large, I would say. Yeah, so this is the temporal trend because we had data from 20th December till date. We just wanted to see whether it's improving or not. It is improving with time, but still, as you see, like from 30% to around 23% now at the overall India level, this is the hesitancy we can see. Yeah, so here we want to look at some specific states which have contributed to the majority of COVID cases in India. And also we have considered states where we have seen lower hesitancy and states where we like Kerala, etc., Kerala, Chhattisgarh, and we have also included states where we have seen higher vaccine hesitancy like Tamil Nadu, Punjab, etc. So we wanted to see the trend. So for some states, you can see a declining trend like Delhi, Maharashtra, MP, West Bengal, etc. But in some other states like Kerala, it's flat 20% all along, you can see, and Punjab and Tamil Nadu also it's flat 40% all along, you can say. In Punjab there is a recent decline we can see, but Tamil Nadu it's still the same. There's no decline as such. And how does that impact the actual vaccination? So here we have the percentage of people received 1 dose of the vaccine and 2 doses of the vaccine. Okay, and each data point represent the districts within that state. So naturally, the number of percentage of people receiving 2 doses are low all over. It's in most states it's low. That's understandable. But the striking thing is that the percentage of people receiving the first dose of vaccine is much low in Tamil Nadu compared to any other states. I mean, if you look at the Tamil Nadu district level estimates, so other than the first one is Chennai, so that's a bit higher. After that, you see it's declining and it's even below 5% in most of the districts of Tamil Nadu. The percentage of people receiving just the first dose of vaccine, which is an area of concern. Whereas in most other states, at least the first dose of vaccination percentage is relatively higher. It's like 10%, 15%, 20%, etc. So that kind of suggests that this hesitancy is directly kind of related to the actual vaccination that's happening in the field. Just one point that even that we have approved vaccines, etc. It is important that we continue following up. We continue doing follow-up studies to understand the actual effectiveness in this real world scenario. So that it's known as the phase 4 trials, and some studies are coming up, but I think the vaccine manufacturing companies have a role to play here. They can't just stop following up the cases, etc. What's happening after vaccination, even though the approval has been given. Yeah, I think now over to Anirudh.
Thanks. Thanks, Santanu. I just wanted to quickly talk about a little bit of survey data that we've collected recently using an online survey with our colleagues at BIAS. So BIAS is Behavioral Insights Architecture Strategy. And this is joint work with some of my colleagues, Sujoy Chakravarti and Shagata Mukherjee and my colleagues at BIAS. So the intention was to sort of supplement an ongoing survey that we were doing on studying other preventive behaviors, mostly related to mask wearing and social distancing and things like that. So me and my colleague Farzana Islam were mostly working in the behavioral sciences. So we were interested in understanding sort of what are the many different potential factors that could be affecting these behaviors or determining whether or not people undertake these behaviors. And slowly, when news of the vaccine started coming out in Jan, as Santanu was discussing earlier, we also were became interested in understanding potentially about vaccine hesitancy. So we had a set of questions of around 518 people, and we asked them about things like how likely they were to take the vaccine when it became available, whether they had any concerns about the ingredient, side effects, or the cost of the vaccine, whether they thought that the vaccine would help them prevent them from getting infected from COVID-19, and a couple of other questions on sort of COVID-related factors, including information. And this is still work in progress. So what I'm going to present is still like very preliminary aspects, but we thought we would present some understanding of regression analysis to try and understand how these different factors sort of affect how likely individuals are to take the COVID-19 vaccine. So these are just graphs from that regression, and the red line just indicates an effect of 0. So it means that that particular variable has no association, or we're not able to find a statistically significant effect of that particular variable on vaccine uptake. So there are two kinds of two sets of questions that we were asking. One is questions on sort of this vaccine hesitancy index, which basically comprise of concerns around side effects, ingredients, and cost, as I mentioned earlier. So that seems to be predicting whether or not people take the vaccine pretty significantly. So the more hesitant you are, the less likely you are to report that you would take it. When we include additional sort of information on whether people believe that COVID-19 vaccines will be effective, then we find that that actually supersedes many other beliefs about costs, side effects, adverse effects, all of these things, including other behaviors that people might be taking part in, such as mask wearing or hand washing. So they find that basically, if they think that the vaccine is effective, then they're more likely to take it. We also were interested in sort of looking at the role of information, which I know that Nanditha will be speaking about next. So we were kind of trying to understand whether information coming from any particular sources, perhaps, especially related to COVID-19, has something to do with vaccine uptake. But there's not much that we've been able to find so far there. And lastly, we have some information on testing and potentially self-reported, infection status. So one of the interesting things is that if someone reported or they thought that they were potentially infected but had not been tested, they were actually less likely to indicate that they were taking the vaccine. And one of the hypothetical vaccine choice questions that we had was sort of a choice between having a free. So this was, mind you, this was before we learned about pricing and we learned about the different varieties of vaccines that were going to be available for the general public. So we had a hypothetical question that asked about whether people would take a free Indian vaccine versus a priced foreign vaccine. It's a kind of to try and tease apart whether there was some cost effects, whether there was some sort of vaccine nationalism sort of things going on. Here also what we found was that vaccine hesitancy has sort of a positive understanding. So people who are perhaps concerned about side effects, about the cost, about the ingredients, those are more likely to say that I will decide on the basis of relative efficacy of those vaccines. So that's why including the information parameters were kind of important for us, because perhaps most people get information about the relative efficacy of vaccines from some of these sources. So as you can see, people who perhaps get information from newspapers and magazines, the internet, are more likely to say that I will make my decision on the basis of some relative efficacy numbers. So I think that's all I want to say. I don't want to take up too much time. I'm happy to answer any questions before. This is still work in progress, so any comments would be very helpful. Thank you. I'm going to pass on to Nanditha.
Thank you, Anirudh. So we at faculty wanted to explore this vaccine hesitancy concept from the mis and disinformation lens. So before diving into what makes vaccine hesitancy so complex, I'd like to first discuss the basic difference between mis and disinformation. So misinformation is when you're randomly scrolling on your social media and you unknowingly share a catchy headline and you end up sharing it on your timeline with your friends or your colleagues. That is termed as misinformation when you share some false information unknowingly. Whereas disinformation is a deliberate effort to actually mislead people into believing something that is false. So this is the definition of mis and disinformation. So why is there so much vaccine hesitancy was the problem statement that we had come across. So again, vaccine hesitancy is not an old concept. It is not a new concept. It has existed from the time vaccination as a concept has come into existence. So with respect to COVID-19 vaccination, some of the issues that we have come across is that there is overburden of information. There are a lot of falsehood, there are conspiracy theories, and also there are wild rumors about, like Santanu and Anirudh have been discussing on the safety and the efficacy of the drugs. And as such, people scrolling on social media have limited attention span. They only tend to look at a catchy headline and they don't essentially delve into knowing what the truth or the fact of the article is. And also we have realized, and we are trying to quantify the religious and the political polarization, how much of it has an effect on vaccine hesitancy. And also we have seen a number of rise in YouTube channels and other Facebook channels where a lot of people are deliberately spreading false rumors on this, because they're making a lot of money off the internet right now, because a lot of these videos tend to go viral and shared rapidly, especially on like say WhatsApp and closed group chats where you cannot essentially track what kind of information is being shared. So that is one of the key issues that we are struggling with, as to how do we regulate closed spaces like WhatsApp. And also a lot of information is shared in vernacular languages, in regional languages, where essentially you need different algorithms to track them. Some of the common myths and misconceptions that we have come across, and this has been going viral since 2020, and it has resurfaced again in the context of the second wave, that the vaccines have been linked to autism time and again. We have been trying to debunk it as much as possible, but still people tend to believe that their children are going to be autistic, or like they're going to the vaccines are going to induce a lot of side effects in them, that it will alter their DNA, or they have random beliefs, and they do believe that, and some of them do believe that COVID does not exist and it is just a conspiracy theory till date. And also people believe that it will induce, like say, animal-like traits in them, or that it will it's that the vaccine is going to inject a microchip and they're going to control your movements using 5G technology, which has no scientific basis whatsoever. And people, again, they do tend to believe these things because these are very psychological in nature. And when especially shared in like close-knit family hierarchies, when it is shared on our family groups, they don't tend to check the source of it, but they believe the information as in how they receive the information. Yeah, again, a lot of people believe that this is a Bill Gates conspiracy theory. No matter how many times you try and debunk this, the truth, as we know, that does not go as viral as how the misinformation does. But people do tend to believe that a lot of these catchy headlines, and they think that they have if the country, for specific country like India has had a better recovery rate compared to other countries, they think they do not require vaccines, or that they think that some of the containment zones or some of the districts have achieved herd immunity, and such WhatsApp messages and Facebook messages have been going viral, and people tend to be against vaccines. And also they think that through vaccine injecting the vaccines, there'll be the creation of more variants, as we have seen in the context of UK vaccines. A lot of this misinformation is very descriptive and qualitative in nature. So one of our issues that we have been struggling to find out is how do we quantify and how do we debunk this information. So some of the things that we have understood from our experience as to how to combat this misinformation is through these following ways. So as you can see the spectrum of graph here, you have on the spectrum of people actively not seeking vaccines to actively seeking vaccines. It is the middle population that we need to target, who are kind of skeptical as to what this vaccines are going to do to them. Like there is so much uncertainty that they don't understand the science. So we as fact checkers and fact checking community, we realize that telling people the science behind it, telling people the facts and figures of the vaccines is extremely crucial for them to believe that what these vaccines essentially stand for. And also recently we have seen about how menstruating women should not take vaccines and so on and so forth. And we were able to debunk such misinformation through actively giving them the correct information through social media influencers, or even putting up fact checks. And right now also, when you access Facebook, there is another extra additional step that you need to do it when fact checkers label misinformation, whether it is partly true or false or misleading. And also, one thing that we as individuals should actively do is to pause, stop, and spot. Whenever you read a catchy headline, or whenever you read any information for that matter, especially when you receive on WhatsApp or whenever you read on social media, it's very important that we inculcate the habit of being inquisitive. We need to spot and question whether the source is correct, question whether the facts are correct, question whether it logically, if that makes sense. And also we have realized in our experience that there is a celebrity effect, which when the celebrities endorse vaccines, it has definitely improved, not significantly, but it did improve the vaccine uptake as such. When the politicians and the celebrities have started to come up and take vaccines and putting up pictures, it did inculcate a confidence within the people, and the uptake did improve. And also when we talk to these anti-vaxxers or anti-vaccination people, it is very important that we listen to where they are coming from. We have to avoid coercion and listen from what point they are coming from, what is their source, and we need to understand and engage with them as to what is their concern about vaccines, and lead them to correct sources, trustworthy sources. And this is where effective communication becomes very important, and we as fact checkers are onto that duty to put out the correct information out there. So whenever you have any question about believing in certain topics, you just have to Google the keywords, and a fact check will definitely appear on the question topic. That's about from me. Excited to participate in the rest of the conversation.
Yeah, thanks, Nanditha. So I think let me start with a question directly to Dr. Brighu, if that's okay with you. So, given your involvement with the planning of the massive vaccine rollout that started on 16 Jan, I mean, what we found that the entire focus was on the logistics of vaccine distribution, identifying the priority groups, whether to make it freely available to the targeted beneficiaries, developing the app and the web portal, conducting trainings of vaccinators and undertaking dry runs of vaccination activities, etc. So all are related to the supply side aspects of vaccination. So I would like to know more about the thought process that went into the planning, and also, was there any discussion around vaccine hesitancy and how that might impact vaccination uptake? Any mitigation strategy that was discussed? And also another question I just want to add, looking back, so do you think that the vaccine priority groups could have been selected differently? So Dr. Brighu.
Thank you, Shantanu. Thank you. Let me try to answer. There are multiple questions in that, but let me try to answer some basic facts that we need to first. The first fact that we need to know is that we were introducing a vaccine which was not existent globally before 2020. So we were introducing a new vaccine. If you look into the immunization program, we were targeting a group that was never ever targeted inside a public health program like this. So it was also looking into it. The scale, size, and shape, everything was unique when we talk about. And when we look the entire journey of vaccine, in fact, January 16th was the starting day. The vaccination preparation started way back in September, October. We were working inside that domain in the past 3 or 4 months when we didn't even knew which vaccine will come, to the level that we didn't know whether a Pfizer of minus 60 degrees vaccine cold chain requirement will come, or a vaccine of 228. Will it be 2-doser, 4-doser? What will be the limitations? What will be the contraindications? All of that. And that was all happening within the pandemic. So first thing that I would like to correct or inform is that it was not just the operational part. So if you go to the ministry's website, you will find 2 documents that are there. One is the operational guidelines for COVID-19 vaccine rollout. The other is the strategic communication for COVID-19 vaccination. So in fact, ministry prepared 2 separate full-fledged, the operational part was all packed into one, which also had a communication piece, but it was very well realized that the communication piece or the discussion piece will require a very special attention. And the special attention here will be twofold. As against in our routine immunization programs where we vaccinate children, where the major focus is towards vaccine hesitancy, we knew that there will be some people who will be hesitant, and this hesitancy will range from a mild as skepticism to a fully resistant families, which is a very small lot. Here we had a dual challenge where we knew that there will be hesitancy also, and there will be eagerness also. And that was very well vigilant when we started with the first age group of first cohort of healthcare professionals, where there was extensive hesitancy, start with doubts, questions, things, to the day of 1st of March, where our parents and grandparents of 60 years and all were running outside a health facility to get vaccinated. If you see pictures that were running from Bandra Kurla of Mumbai on first day, I was really worried seeing the amount. It was as if the first day first show movie ticket was getting sold across. And that is the eagerness. So both those things were there. And if you see the entire journey of vaccine hesitancy, it's basically a fast forward of the entire normal process that happens into a vaccine introduction. In a normal process of vaccine introduction, whether we talk of a pneumococcal vaccine introduction, rota vaccine, you slowly build up confidence. And then you slowly build up confidence into the people. You slowly reach out to the targets. If you see the MR campaign that we did, the MR campaign actually took everyone to the 15 years of age. So it had children, it had infants, it had adolescents who were all there, and it was a school age group population. Again, and not a population that we touched across, but it was phased. We did that entire campaign. We touched around 325 million beneficiaries all across. But that was a 3 years process. We were doing state to state, moving across pieces. Here it was all at one go. So in that phase, all these pieces were brought together. You also didn't had a very clear understanding of which tool, and so you had to prepare the entire gamut of preparations that when hesitancy takes over, these are the tool points and these are the clarifications. When eagerness takes over, how do you bring in the eagerness? There were questions across when you talk about eagerness as to why only 60 plus. Okay, so now if we shift back the question to choosing the right target population of why healthcare providers or why frontline workers. So first is, if you look into the global guidance that came from WHO and the global guidance from SAGE, it was very clearly said that the first priority is healthcare worker. And if you look into the entire gamut, the most common people who were getting affected with COVID were people who were giving services. We lost 330 doctors in 2020 just because of COVID, and much more. These are numbers that just came across. Many of our friends gave their life and went into severe illnesses during that. So it was a very clear choice, globally known, that the first thing, if you have very limited amount of vaccine, it should go to the healthcare workers, because these are the people who are repeatedly seeing patients. the second choice of bringing in the frontline workers. And when I say healthcare workers, let me clarify the definition. Healthcare workers was not just doctors or nurses. It was anybody who was associated with the health system. It was doctors, nurses, lab technicians, ward boys, people who were managing the toilets of the hospitals, waste carriers, frontline workers. All of them were brought inside that bumi because all of them were getting exposed. So it's a natural choice when you have limited resources, when you have a pandemic which has not gone through across, you had to make some choices whom to prioritize, and that is why that was the prioritization. And what I can say is that this was a common piece in conjunction with the global guidance. If you see the COVAX facility, which was globally created to support, it very clearly said that the first supply of vaccine to every country will be just 3% to cater to their healthcare workers, because that was the primary audience being talked about. So that in that context, this was the entire piece of when we talk about communication. But and if you trace back, I was looking into the bias study, which had data from January and February, or sorry, February and March. The kinds of questions and the types of queries that were there in January were very different in February and were very, very different in March. Because at one point of time when you started the healthcare workers, the questions were very different. The doctors and the healthcare community was asking questions which had very things on efficacy, clinical trials, phase 3 trial data, indigenous versus international vaccines, impact on this. To a goal where you went into 1st of March, where the general population started, the questions were very different. Okay, diabetic patients, cancer patients, can I get it? Pregnant women, can I get it? What happens to this group? What happens to that group? Which vaccine, which dose? The question shifted in from should I go ahead with this vaccine? The vaccine choice was also very, 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 you said, dynamic. People were moving in. So all of that front had, and today when we stand on this, you might have seen with 27,000 clicks a minute, which started on registration for 18 plus to more than 1.35 crores getting registered. All of that is there, but when you apply the denominator of 1.4 billion people, there are still, so what I now call it is that there is a hesitancy which gets overcovered by eagerness. The hesitancy pockets still remain, the doubts are still there, which wax and wane, which improve, which get across, and with the pandemic going across, it's its own impact going across. I'll stop there, Santanu, and for your follow-up
question. Yeah, just one follow-up question, Dr. Brighu. So I completely agree with the first phase of target beneficiaries being the health workers and the front. There's no question about that. But like the subsequent phases, I mean, do you think the working age group who were mostly going out more often than the 60 plus or age group? So in that context, I mean, do you think there could have been a different approach, or was there any other suggestions that other countries have been following, or?
The second, again, that is a very important part. So let us understand that what vaccine does. Vaccine does not prevent too much of an infection. And what is the target? The target of vaccination is to prevent severe disease, to prevent hospitalization, and to prevent death. So even if the age group that was going outside was younger population, the people who were turning out at the hospital facilities with severe and critical diseases, the risk of morbidity and mortality was much higher in the age group that was targeted. So you 65, 60 plus or 45 plus with comorbidities. And that is why in those resources, and this decision is not just based on one decision. There could be a very clear debate that if we have opened up for 18 on 1st of May, we could have opened up for 18 on 1st of March. Okay, so we could have said that, but this is not just one point discussion points. You have to titrate it with the pandemic, with the supply cycles, what is happening across the globe, how is the production happening, what will be the supplies, and how do you prioritize? So it's a multi-pronged decision. The decisions made at NEGVAC, the national advisory group that has been created, which consists of not just Ministry of Health, but all different ministries and all different experts coming together to have that discussion and debate as to, with these prevailing circumstances, what could be the best choice, what could be the best thing that has been made. So I will not be the right person to comment upon saying that this age group was right. What I believe and what I say here is that this was a decision that was made based on multiple contexts, but not on just one parameter. Considering the risk, it was the at-risk population, the population which is not at risk of infection, but at risk of severe disease, hospitalization, deaths, and those risks associated.
Okay, thank you so much, Dr. Brighu. So let me turn to Dr. Ghosh. I think he has another meeting starting at 12. So just one general question I have for you. So India was doing fairly well throughout the pandemic with a stringent lockdown at a very early stage of the pandemic, followed by gradual unlocking with peak being achieved around October or so in most places, then steady decline in number of cases during November to February for about 4 months. There was a steady decline. And then why so sudden increase starting March or so? I mean, this is particularly strange when we have started our vaccination drive starting 16 Jan. I mean, vaccination, of course, is not a magic. I mean, you need to take 2 doses and then also have to wait for a few days, then the actual effect comes into play. But still, all of these look so bizarre that, I mean, we were doing so well and the vaccination started and the number of cases has started to increase significant. Any specific reasons to pinpoint, or it's hard to tell? Any thoughts?
So yeah, let me attempt to answer that. But before I speak about the rise in the number of cases, let me also just address something about vaccine hesitancy that we really need to keep in mind. This was a wonderful session. I wish I could have stayed for longer. One of the criteria that we will always have to keep in mind when we talk about vaccine hesitancy is that the vaccine hesitancy is always measured in a condition when there is uninterrupted vaccine supply. If the vaccine supply is interrupted, then the vaccine hesitancy cannot be measured under that condition. That is one of the conditions for ensuring that we are measuring vaccine hesitancy scientifically, that vaccines are available, but people are hesitant to go and take that vaccine. In India, in between, we have seen that there have been disruptions in terms of some of the vaccine supplies to some of the states. So please consider that factor when we are trying to measure the vaccine hesitancy. The second point that I wanted to make is that there are multiple segments of population who will keep on changing in terms of their behavior, in terms of vaccine hesitancy. What are the 3 kinds of things that we should look at? One is around the access. We call this the AAA. One is around the access to the vaccine. Obviously, in terms of planning the COVID vaccination campaign, there are multiple things that have to be kept in mind. Most importantly, maintaining the COVID appropriate protocols. Therefore, the centers that were chosen were not always the best kind of accessible and approachable centers for the population. The second thing that we have to keep in mind is around the apprehension, the second day. And there are multiple reports which are conflicting reports. And I think scientists and the ones who have represented the scientists' voice to the general population, there is a lot of room for improvement in order for giving the correct factual information. As Brighu was very rightly saying, the government of India has very transparently laid out on their Ministry of Health and Family Welfare sites about the different kinds of criteria, different kinds of findings, the clinical findings of the 2 vaccines that are being used in India. But obviously, the Covishield vaccine that is being used is not only being used in India, it is the AstraZeneca vaccine is being used globally. There are multiple reports that came in, and obviously that caused a lot of apprehension amongst the community. The third thing that we need to keep in mind, and this is particularly important for COVID vaccine, and which we will see probably in the future, is the third A, which is affordability. The affordability, we do not know how much that is going to impact the population in terms of their acceptance of the vaccine, but we will have to keep this factor to understand as to what has that been in terms of its impact in the vaccine hesitancy that we measure in the population. I am completely with Brighu when he talks about this conflict between the vaccine eagerness and the vaccine hesitancy. We are now also seeing that there are lots of centers across the country where there are lots of people who are waiting in queue to receive the vaccine. We are hearing of, today morning I read in the paper that Maharashtra has now decided to stop vaccination for 3 days. There's a lot of outcry over that. So there is this very complex dynamics of vaccine eagerness and kind of vaccine hesitancy because of the access, apprehension, and affordability that might come in. So therefore, this is going to be a very interesting kind of study for the public health researchers to understand the full dynamics of vaccine hesitancy. Having said all of that, you asked a question around why did we have this sudden surge of cases? Now, generally what we have done is that we have found the 2 villains in this whole process. One is the virus, that the virus mutated and the virus sort of behaved in a manner in which we were not expecting. So that is one of the villains. And the second villain is, the people who did not follow the COVID appropriate behavior. They sort of crowded, they sort of did not mask themselves. But two things we need to keep in mind. One, that we were always aware that the virus would mutate. It is the nature of a virus to mutate. How the virus would have reacted, that we could not have predicted. But we did know that viruses mutate, and therefore the virus followed its natural phenomenon. The second is, and I have written this in multiple places on social media also, is that none of us probably had ever thought that people will suddenly overnight change and adopt COVID appropriate behavior and start behaving very scientifically. We knew that there will be a large section of the community who will be late adopters of the program of the COVID appropriate behaviors. We sort of prepared in that manner. We sort of used our social media. We used all our social mobilization, behavioral change communications in order to address that issue. But somewhere, it took more time for the people to really adopt to this behavior. Probably now, that kind of a culture and that kind of a peer pressure is going in the community in order to understand that there is a large problem that happens with not adopting to COVID appropriate behaviors. So therefore, we do expect that now that, this culture is coming in, we will be able to do some of the, some of the checks that we are seeing in the community. But overall, giving an answer to your question, I will not say anything which is dramatic. We do know that the virus mutation, we had not expected the severity of it. The second is that, the COVID appropriate behavior was not followed at many places. And it is not only about the people. We all know that, many other things happened around the kind of crowding, the kind of rallies that we saw, the kind of conglomerations, the crowding that we saw. All of those could have been prevented. And third, I think that, the vaccine coverage has been one of the dramatic rises in India, but the vaccine coverage, we should have probably prepared better and probably covered a larger and wider group in order to prevent the pandemic. With the kind of efforts now being put in place, let us see how we can do that for the future pandemic. Thank you.
Okay, thank you so much, Dr. Ghosh and Dr. Brighu as well. So just if anyone has any specific questions for Dr. Ghosh and Dr. Brighu before they had to go, so we can take those questions. If anything specific you want to ask any of the participants, please go ahead now. Otherwise, I can turn to other panelists. Anyone has any specific questions?
Yes, Santanu, motion with dissent.
Yeah, please go ahead.
Yeah, I work at NCEER and I'm an economist. I am not a doctor. I mean, in the sense, I'm not a medical doctor. So, if Moderna is working on a vaccine which will combine COVID-19 and flu vaccine, so given that India is a tropical country, and given the spread of cold, cough, etc., so do we see a possibility of a combined vaccine in future? And also, how do you think then India should go about addressing both these issues in one go? I mean, what kind of a strategy would leading organizations adopt? And also, if you could share some resources on the kind of policy papers or strategy papers that are being adopted to target everybody, all age groups.
So thank you, Moshami, for that question. I think the way and the stage that we are running at this pandemic, the future changes every day. There are multiple vaccines in pipelines, many of them more than 90 into different stages of clinical trials. So there are two problems. The one is problem at hand. The one is problem at looking at the future and how the entire COVID and the COVID pandemic will settle it across in the coming years. So having a combined vaccine is a little distant talk about that. When it will be available, things will be seen into the context of where we are in the pandemic. As of now, it is more towards getting the COVID vaccine and getting the people immunized. That is one piece. The second part of your question on the age group, I would just say that as of now, with 1st of May, the entire age group that is eligible from the vaccines, because these vaccines at this point of time have not been the data is not available for adolescents and people less than 18. So when all the age group is now open for vaccination, and when the data will come in for adolescent and pregnant women and lactating mothers and children, those kind of decisions will be taken across to move forward, which will be the expanded age group, which will be included based on the data that come inside. So as of now, we are open for all the age groups that are eligible for vaccine based on their data sets.
Anything you want to add, Dr. Ghosh?
I think Brighu answered it perfectly. Thank you.
Yeah. Okay, so thank you so much.
Hi, this is Rishabh. I'm from Quicksand, principal here. I had a question around the fact that the way that Covaxin was sort of like approved and the urgency that was kind of shown, that urgency, while being positive, also sort of had this impact on people's psyche that things were being rushed without being tested. So just your thoughts on that, and also your thoughts on whether this accelerated approval of other vaccines like Pfizer and Moderna that now the government has sort of gone ahead with. Should that decision have come earlier? And would that have helped create a critical mass of people who got vaccinated, so hesitancy would have probably reduced because of that?
Just try to attempt to answer that, and then probably Brighu can add a few words. In terms of the emergency approval of vaccines, this is what emergency approval means. It obviously has its own kind of set criteria in terms of how the vaccine is approved by the drug controller. I just want to state two things. One, that the Drug Controller General of India, the DCGI and the CDSO, are bodies which have the highest kind of accreditation or kind of reputation, and have complete WHO's confidence or global bodies' confidence in terms of the job that they do. Therefore, the kind of approvals that they did at that point of time was in need with the hour to have the number of products, to have a large number of products in order to address the need. The second question that you asked about, whether we could have taken a decision around the Moderna and the Pfizer vaccines. One of the things that is important is when regulators or when program managers look at it, is obviously, as you understand, the compliance of the product with the system. The kind of infrastructure that is required in terms of the ultra cold chain for these vaccines to be rolled out at a large scale or at a mass scale was not possible at that point of time. Currently, we will see as to how these adapt into the system now that it has been opened up with the private sector also, how they kind of adopt it within their systems. So everything has a time. Certainly, there are many things at hindsight that we could have done better, we should have done better. But most important thing probably that we could have done is to have a much, much higher coverage. We sort of, tried our best, the government and all the partners together. There were certainly certain issues because of which the coverage reached up to a certain point. But the kind of progress that it is now making, I will say that, we should be optimistic that it will be moving forward well, provided we have a regular supply of the product. If we don't have the product, then obviously whatever plans we make, that will not be successful.
Okay, thank you so much, Dr. Ghosh. So let's hope eagerness sort of trumps over hesitancy. So now I'm turning to our other panelists. So another to Dr. Dasgupta, another strong determinant of vaccine hesitancy, perhaps even stronger than the rushed vaccine development and approval process without efficacy data, is perhaps the extent of severe and serious adverse events following immunization, including deaths. So, I mean, people would come to know about AEFIs from different sources, mostly anecdotal. I mean, irrespective of whether the AEFIs are communicated to the masses in a transparent manner or not, people will come to know from different sources. So being a member of the National AEFI Committee and being a part of the AEFI Causality Assessment Committee, so how has been your experience with COVID-19 vaccination compared to childhood vaccination? And in general, how is your sense on vaccine hesitancy for COVID-19 vaccination and its association with AEFIs?
Thank you, Santanu. Do you mind if I don't answer the question directly?
Yeah, please. You can address any issue you want.
Okay. But before I answer the question, I have two questions to ask about the study. First is these samples, the respondents who were surveyed, what unless I missed it during the presentation, what is the social composition or the social demographic composition of these respondents?
Yeah, so regarding the Facebook study, you are very right. I mean, of course, whether it can be generalized to draw inference at the population level.
No, I'm not even asking. I won't get into that. I won't step into that. I'm simply asking social composition.
Yeah, I mean, it's of course more urban, and it has more male than female, and in terms of age group, it perhaps is not bad. But what I want to emphasize is that so what Facebook did, they created a survey weight because they have a lot of user data, which only they have. Based on that user information, they have created a survey weight, which essentially meaning that those who are less represented in the sample, they weigh them up compared to those who are more represented, they weigh them down. So that so they have a two-step weighting procedure. There's a detailed paper on that. So we have done some validation also of their weights, whether it can be used for general population inference, etc. It is not bad. After one uses the weights, it does a decent job in terms of representing the population. Yeah.
Okay, but it's essentially urban, and those with, or at least predominantly those with access to social media, etc.
Yes.
Okay, fair enough. And my second question is, when you conceptualize the study and prepare the tool, what is the kind of literature that you drew upon to prepare your tools, and in specific the themes or sub-themes within those tools?
Yeah, I'm sorry for not being clear. So this is a survey we didn't do. So this was done by Carnegie Mellon University and University of Maryland, using the Facebook user base as the sampling frame. So Carnegie Mellon University is responsible for the US survey, and University of Maryland is responsible for the entire world survey. And they have consulted with public health experts to come up with the tool, etc., including some people in India, etc. So we were just a user of their data. Okay, so just want to clear that.
Okay. In which case, I mean, not in which case, therefore, what I would really like to draw your attention on, I mean, on the group's attention, I would like to really share with the group that vaccine hesitancy has a certain definition and a certain thematic understanding, which is actually not, of course, I haven't seen the tool, but from what is presented, it doesn't seem to be adequately represented in this survey. And at least in my understanding, that framework, or at least those domains, are very central to a systematic understanding of vaccine hesitancy. What instead this has become, or again, I apologize, that's on the basis of the presentation. There may be a lot more than to it than a 15-minute presentation, to be fair, is more of a quote-unquote perception study, which otherwise one can take a grounded theory approach and see what is emerging, which is what something can be done, for example, and I say this a little rhetorically and lightheartedly, of, let's say, the demonetization experience. And I therefore make the distinction between a perception study where nothing is known and there's a new event or phenomenon, and therefore we are looking at what is emergent, versus things that are known and has a certain structure, certain structure arrived at through research and consensus criteria. There are 2 or 3 things essentially to understand. First is that there is something called the vaccine hesitancy continuum. So in this continuum, it moves from a pole to the left-hand side of high demand, which is accept all, to a pole of no demand, which is refuse all. So, and the intermediate steps are accept some, and then delay, and then refuse some, and then finally refuse all. That's one kind of understanding. The other understanding is what is known as the spectrum of intentions. And the spectrum of intentions move from one pole to the left, this also moves from left to right, but in the opposite direction. So in the spectrum of intention, what's to the absolute left is what is an activist position of what one of the presenters presented as anti-vaxxers. Now, often this oversimplification gets done that almost anything is anti-vaxxers. Actually, it is not. Actually, it's a minuscule minority which is at one pole to the left, which itself is an activist position, and then to rejecting, to hesitant, and then to accepting. So it's like a sigmoid curve, like a bell-shaped curve, with accepting at the top, because that's really the median, so to say. And then and these terms are actually oversimplified terms: vaccine hesitancy, vaccine what is it, Brighu? Vaccine enthusiasm. What is it, Brighu? Vaccine enthusiasm.
Eagerness.
Eagerness, right.
Eagerness, yes.
Right. Now, these are, I'm sorry, these are absolutely commonsensical terms. So there is a demand, then beyond accepting, there's a demanding, and then finally there is an advocating. So the advocating is exactly the opposite pole of the anti-vaxxers activism. So this is what is called the spectrum of intentions. Now, this is the background. This is the background, whether you take it as a vaccine hesitancy continuum or as a spectrum of intentions, then that it moves into what is known as the 3 C's model. So in this 3 C's model, the 3 main C's are confidence, complacency, and convenience. Now, both Brighu and Raj in their in their presentations, in their explanations, did dwell upon all of this, but I'm just saying how vaccine hesitancy arranges these thematically. So this 3 C's model originally came from the WHO Euro Vaccine Communications Working Group, 2011, if I'm not wrong. Sorry, 2012 perhaps. And then later the global the SAGE of the GVAX adopted this essentially. And then confidence is therefore defined as trust in 3 things. 1 is the effectiveness and safety of vaccines. 2 is the system that delivers them, including the reliability and competence of health services and health professionals. And 3, which is very crucial, and all of these, you will realize all of these threads has been in the discussion so far in the presentation. 3, the motivations of policymakers who decide on the needed vaccines. That's the first C. The second C is complacency, that exists where perceived risks of vaccine preventable diseases are low and vaccination is not deemed a necessary preventive action. And 3, convenience, which is what Raj was alluding to in several different ways. So confidence is a significant factor when physical availability, affordability, willingness to pay, which is what we are seeing now, geographical accessibility, ability to understand, which is both language and health literacy, and the appeal of immunization services, all of which have a relevance on the uptake. So these really are the three elements, or the 3 C's, which is confidence, complacency, and convenience. Now, finally, and this is what Brighu said right at the beginning, and very correctly, that despite all of our knowledge and experience and the tremendous depth that exists, and we are very justly proud of in the Indian immunization program, it is a new vaccine, and there are completely unforeseen challenges, not just of program rollout, as Brighu said, and Raj also said. Now the additional challenge for the COVID vaccine are 4, and this is how I categorize the 4. You can of course categorize in somewhat different ways, but essentially drawing upon the existing structure of vaccine hesitancy, and these are all elements we have discussed. So there's nothing new that I'm saying, but just how to categorize it. So the first is around product development. So all this debate and question and discussion on emergency authorization, the ethics of it, etc. The second is prioritization strategies. In the prioritization strategies, as Brighu explained, one approach has been, okay, let me put it this way. All approaches, by all approaches, I mean approaches in all countries, have been around risks. The difference is or the differences have been in how you conceptualize that risk. And the conceptualization of that risk, again, is not really the conventional sense of risks. By risks, I mean vulnerabilities, health vulnerabilities, but the vulnerabilities that have specifically emerged in the context of the COVID epidemic experience. Now, this notion of risk that India has undertaken, which Brighu explained, is only only the risk of mortality. That's but only one notion of risk or one element of risk. So what the ACIP, the American advisory body, what it did was, it actually had, if I'm not wrong, but Brighu may have more details, Raj may have more details, it actually deliberated for nearly 2 months. And I don't know, Brighu may know how many actual sessions our NCAER had, not more than 2 sessions, if I'm not wrong, 2 to 3. It actually debated for 2 months what those notions of, what the emergent experience of risk was in the US context, of course, in the context of that data. So that included race, that included work profile, that included who is actually able to work from home and who aren't, that included workplace profile. Age was one of these. It included the housing profile. So age, remember, age emerges as a very high risk category in the US, UK, and Western Europe context, which actually has a confounding with the institutional setting in which you live, whether you're living at your home or whether you're living in an old age care institution. So there is a confounding there. Age alone has a certain quantum of risk, and age overlapped with care settings has a completely different measure of risk. Now, the reason I'm saying is that the ACIP debated to arrive at what notions of risk will you ultimately adopt in the program, and that's very crucial. So this age is only, not age, it is the mortality which is the only notion of risk that our NCAER considered in its own wisdom. But just to raise the point that therefore there's these elements of risk. Now what has that got to do with hesitancy? Now, obviously, hesitancy or demand is a function of risk, of my perceived risk. This is the perception of the risk by the NCAER, okay, which is not necessarily my perception of risk. So today, for example, any workplace that is open for the last few months is today practically shut, because practically all members, all employees of those organizations are either sick or dead. And that includes, by the way, the ICMR headquarters in New Delhi, which is almost a ghost building today. I won't even share the number of deaths, but believe me, it's just shut today. And another ICMR regional institute, I heard this morning, virtually all of them are ill there, including deaths, including some very tragic deaths, to the extent that the bulk of the project staff there are considering resigning. And that is a very, very crucial ICMR institute in an extremely crucial state where the epidemic is spreading, if I may, like wildfire. Now, these are the notions that will continue of risk that will constitute hesitancy, demand, etc., etc. Okay, that's about prioritization. The third is about program rollout. So the first was about product, and this is in specifically context of COVID. The first was about product. The second is about prioritization. The third is about program rollout, and this is what keeps Brighu sleepless at night, of what is happening. I mean, Brighu and many others, like of Brighu's colleagues across the government, across the agencies, they really spend sleepless nights on the program rollout. And again, the experience of the program has a bearing on demand, hesitancy, etc., which Raj was explaining, that you can only seriously talk about hesitancy when there is a program. And if there is no program, in that sense, that now there's a disruption in supplies, etc., how do you actually understand hesitancy? And finally, the AEFI, believes me, comes at the end. So this is the whole spectrum in the context of COVID. AEFI therefore really comes at the end of what the known adverse events are, how we are investigating and communicating adverse events, And because it's a new vaccine, as all of us know and have been emphasizing, so over and above these these known adverse events, there is an unknown, but to a certain extent, expected set of events, which are called AESIs, or adverse events of special interest. So not only do we need, just like a functioning program, as they were explaining, and believe me, we are sleepless also, just as we need a functioning program, we also need a functioning AFI component or element, not just to systematically investigate, but to be able to share those findings, including the suspected events. For example, in the case of the AstraZeneca, we know of the suspected thromboembolic events across the world. How the extent to which we are able to identify those, investigate those, come up with good science around those, and be able to communicate it both with program managers and the medical fraternity who are actually going to diagnose those cases and provide services, plus these vast millions of vaccine recipient candidates, including those who have already taken it, to be able to communicate with them the safety profiles, how the program is responding, how the program is taking care, and therefore that has a very strong bearing on hesitancy, confidence, etc. And as Brighu and Raj explained, and as you yourself have also accounted for, that this is absolutely a dynamic event, and what you have done is absolutely wonderful, and therefore one actually needs rounds of that to be able to track what is happening to this mix of responses across time and across these different phases of program. Sorry, I probably took too much time.
No, I think that was really helpful to provide us with a sort of a theoretical framework for hesitancy, because those are the things we tend to overlook in such times and try to come up with quick estimates. And also explaining the risk and the priority groups, identification of priority groups. I think that was very, very helpful in the whole discussion. And
if there are any follow-up questions, I'm happy to answer, of course.
Yes, yeah, definitely. And but let me first quickly return to Dr. Farzana. She has been patiently waiting. So Farzana, if I may ask you one question. I know you have been involved with the vaccination drive since the beginning, like starting from 16 Jan or even before that with the planning, etc. And I'm sure you have a lot of insights and challenges that you have faced during the process. And so we'd like to know more about your experience on that, and in particular compliance to vaccination doses. I mean, are always people getting 2 doses of the same vaccines? Are there demands for specific vaccines and not for other? And what is the time interval that you are following between the first and second dose for Covaxin and Covishield? And is it possible that some people are getting 2 different vaccines as the first dose and the second dose? And I mean, if that is the case, I mean, what is the evidence on interchangeability of vaccines? Any specific guidelines that you have been following, etc.? Yeah, please go ahead.
Thank you, Santanu, and a very good afternoon to everyone. And I was just listening to everyone, every aspects of like right from the planning, right from like Dr. Brighu was telling, like right how did they plan, and they prepared all the guidelines, and they took care of sorry, every aspects of implementation and everything. And I would like to start before answering your question, Shantanu. I'd like to just start with a little background how we started, as we are actually the implementers. We have seen how the process has started and how the process is going on, and what are the different perceptions of people, what is vaccine hesitancy, and everything. We have seen it with our own eyes, and we are experiencing everything. So first of all, I am associated with this 100 Institute, and the first thing is that we are very lucky. Our department, Community Medicine Department, got we are running the vaccination center, and we have got all the support from our authority, right from choosing the venue. If we start from first the choosing the venue, because the government has laid specifications like 3 rooms should be there, like observation. So we have to first decide on the venue and everything. And then that is the thing that our authority, right from Dean, MS, and everyone were very supportive and everything for us to roll out the work. Secondly, our team, our nodal officer, Dr. Aksa, and our entire team of our postgraduate students, and everyone worked very hard to make the program successful. So initially, when we started with the things, when we rolled out on 16th January for the healthcare workers, so very strangely, we noticed that coming for vaccination of our own healthcare workers, because initially we started with our own healthcare workers. There are very less, their very hesitancy was much more among the students, MBBS students, among the nursing staff. Very surprisingly, the staffs which were involved, the nursing staff which were involved in vaccinating the other people, they were hesitant to take the vaccines. So these are our observations, and we also started to look upon those hesitancies, like why these are own healthcare workers, even the doctors. Among the doctors, if I say, almost 60 to 70% doctors, they came forward very happily to take the vaccines, because obviously they know the various reasons and everything. But again, the hesitancies are still there, and it was there also among the doctors. But very surprisingly, it was among the medical students and the nursing staff. It was huge hesitancy was there. So when we started to analyze the reasons for their hesitancies, we at least for our institute, we have found that for the students, the side effects were, they were concerned about the side effects. Even when we analyzed all the EUFIs, whatever has happened in our institute, we have seen the fever and tenderness and malaise were the main side effects. But even then, we had to convince the students. We had to motivate them even during the classes and everything. Our office orders came out for them, like you have to go for vaccination and everything. And even we interacted with them, we found out that the parents have told them not to get vaccinated and everything. One more aspects of hesitancy we have seen among the nursing staff, maybe because of some issues which was spread regarding the infertility concept and everything. So that was also there among the nursing staff. They were young nurses and everything, and many of them they got the notion that it might lead to infertility. So that was again and was an issue, and we had to address that, and we tried our best to make them accept the vaccines. Secondly, we also did our best so that as Dr. Dasgupta was telling about the confidence and compliance and about the comfortable, all the C's he was explaining. Yes, we tried our best so that we make them feel assured that whenever they're coming for the vaccination, they're safe. They are not, all the COVID appropriate behaviors we are maintaining. We have kept a proper social distance between, the arrangement was such that. So once people started coming to our center, and then slowly it picked up. So slowly we have seen people are coming, and they are eager to take the vaccines. And regarding the doses, yes, no, we have not seen that people who are taking the first doses and they are not willing to take second doses. No, we have not seen that at least among the all the healthcare workers, those who have taken the first dose maybe. And but yes, when we started taking the charges were introduced, then among the healthcare workers, few healthcare workers resisted initially taking the second dose. They were asking well, in the first dose it was free, and the second dose you have to charge, because as we are a private organization, we had to take the charges. So that was a little problem we faced. But again, it was not that much a problem. That again, we tried our best, and then it was that too. And even as our center was given Covishield vaccine, so it was again somehow the Covaxin controversy and everything. It happened during the early phase, and people were in fact apprehensive in the initial period to take Covaxin. So whoever was coming, and when they saw that it is Covishield, they were happy. Somehow that kind of again information and that willingness for Covishield was there among them, and we were supplied with only Covishield, so we were not given we did not go for Covaxin. And regarding the interchangeability, I don't think it is still approved by any guideline. No vaccine interchangeability is still approved. And for our center, as I told, like it was Covishield. That's why people were very much willing, because maybe only 2 vaccines we have till now, and maybe some more vaccines are coming. But preference for Covishield is more than Covaxin. But this is our observation all throughout our vaccination program.
Yeah, thank you so much, Dr. Farzana, for sharing your experience. That was very helpful. So maybe, Rohan, we can have 15 minutes of Q&A. What do you think?
Absolutely. Yes. Yeah, we're more than grateful for whoever's still with us. I see Debashish Barik has a question. He's also posted that on the chat section, but maybe if you can unmute and come on video, Debashish, please go on and you can ask your question to Dr. Farzana.
Thank you, Rohan. I am Debashish Barik. I am working as a fellow at National Council of Applied Economic Research. So my question is to Dr. Farzana. So basically, we have 2 vaccines rolled out in India as of now. As long as vaccine was available only with government's supply, so freely available to people, so we didn't have any choice which vaccine to opt for. But as you know, we are going to get vaccines with payment from May 1 onwards, and there is differential pricing of vaccines. If you are going to get 2 doses of Covaxin, you have to pay around 2,400 in private, and for Covishield it is 1,200 in private. So basically there is a price differential. So which vaccine should we opt for, given the different pricing structure? So is it the vaccine for which we have to pay more, or which one is popular in the sense that government has rolled out mostly the Covishield, and we are aware about Covishield. So we are confused about that. Can you have some light on that?
Yes. Yes. Thank you, Debashish. See, there are at now we have 2 vaccines, and some more vaccines are about to come in next few months. But if I'm a provider from the private sector, so it depends on the private sector which the particular private sector procure which kind of vaccines. And again, there is a huge price cap in between the 2 vaccines, like with Covishield and Covaxin. And if you want to know about the vaccine efficacy about both the vaccines, all of us are already know that it is Covishield is around success around 70%, and Covaxin is around 81%. But we have seen the main aim of the vaccines is not is the main aim for any vaccines. The main aim is to prevent the severity of the disease, to prevent the hospitalization, and to cut down the infection to that extent, so that the transmission can also. It is all the vaccines are similar. Any type of vaccine should be taken for everyone. Like it depends on personal, when it is available to private sectors, and if you have choice in deciding between Covishield and Covaxin, it carries almost the same thing. It depends on you, like like depending on your, like it is 1,200, it is 2,400. It doesn't mean that 2,400 is better and 1,200 is not better. It is everything is same regarding the efficacy and regarding the availability. I think whatever is available and whatever you can afford, I think you can go for any vaccine, and that should be the pledge of everyone to get vaccinated. And depending upon the choice, I think at present every vaccine has whichever vaccines are being approved, every vaccine has more than 50% efficacy, and that is the cutoff efficacy we should have for any vaccines. So all vaccines are safe. All vaccines are having only minor AFIs. Those only our children are only getting whenever they are getting penta or anything. And though as an adult immunization, when we are dealing with adults, and they have so much of questions, and even we faced yesterday only, I had to convince someone that like it is only a minor fever or body ache or malaise. It will not go beyond that. Rather than it will save you from going into the ventilator or going into the oxygen crisis search, what is going on in this present in Delhi or many other places. So it is any vaccine you should go for. It is not that this vaccine or anything, whatever you can afford, you can you should go for. Main aim is to get vaccinated. That's the thing.
We have another question from Arpita. Arpita, do you want to just unmute yourself and go for it? Thank you.
Thanks, Rohan, and thank you all the panelists and Dr. Santanu for this exciting dialogue session. My question is addressed to Dr. Farzana. Since you have been into the implementation of this vaccine rollout since January, mid-January, so have you experienced some sort of vaccine wastage issues during the whole process? Because nowadays people are standing in queue to get the vaccines. But probably earlier during the first initial days, as you said, like people are hesitant to accept the vaccines, to get it even for the free. So what is your experience on that?
Thank you, Arpita. So you want to know about the vaccine wastage, actually. So actually, as I told you, as we were I'm from the private provider, so we cannot afford to waste the vaccines also. that was our one of the main challenge also, because whenever because as we are buying the vaccines, we cannot afford to waste. So we have not faced any major wastage, because we need to calculate the doses along with the beneficiaries. Whenever the beneficiaries were there, how many beneficiaries were there, and then we need to open another vial and everything. So we have to match both the things, and then we have to go for opening the next vials and everything. So vaccine wastage and everything we have not faced. It is a very minor wastage we have made, because we cannot afford to waste. Wasting one dose means we are wasting 250 rupees. So that's why we were very careful about the vaccine wastage, because we had to calculate based on our beneficiaries and everything. So that is the question. But
because we have heard some news in the probably from the government PHCs or some centers, like they are asking people to come in a group together so that they can open a vial and they can use whole of it for all the beneficiaries. So you haven't faced such issue?
Okay. Yes, we have.
That's great. Thank you so much.
Thank you. There was just one more question that I see was in the chat and I think got missed out. This is both to Dr. Farzana as well as the rest of the three presenters, actually. This is a question from Priyasha, and she asks what specific factors we should bear in mind when designing social behavior change communication for vaccine uptake. So maybe if each of the speakers could take a shot at that.
Right now, like I think we have discussed a lot about the vaccine hesitancy and again the vaccine eagerness. In the initial part of implementation, we have seen lots of hesitancy was there, but now at this moment, when the situation is in a very crisis situation, it is a very like exigency situation. We are seeing vaccine hesitancy. Vaccine eagerness. So thing is that again, like when we are planning for a BCC or anything, we first few important factors which are, I think we should always keep it in mind. The accessibility of the vaccines that Dr. Ghosh has always mentioned about it, availability and the side effects, because this is an adult vaccination which we are going we are running, and we have seen many people, they are quite apprehensive of the vaccine. It is many apprehensions. Most of the apprehensions are because of their what will happen if, and many rumors were also associated. Few incidents also happened following vaccination in various all over the globe. So those hesitancies, like those incidents, I think if this can be have a very clarity, so these are not directly related to the vaccination, the causation of those incidents are not directly related to the vaccinations. I think this can help people. And at the same time, when it is always that the time always tells people, like now when everyone, we have seen now in our hospital, in our institute also, we are seeing those who are already vaccinated, they are not getting the disease, and those or even if they are getting, they are very mild. But again, it is very obviously we are seeing in our hospital also, those who have not got vaccinated, they are getting the severe form of disease. It is a very if we start doing some research on that, it will be very obvious demarcation, even in our colleagues, the elderlies, or the like even the other age group, those who are not vaccinated, they're getting the severe form of the disease. And even in our friend circles and everything, and those who are vaccinated, even with the one dose, the severe form of the disease is not there. Either it is mild, or even if they're going to hospital, they're coming out of the hospital safely. So these are very important points, like availability, misconception, accessibility, and assurance to the people regarding the side effects, and that the vaccine is safe, and that the vaccine is not causing any serious damage rather than the COVID, which can cause. So these are important points, I think we have to look up.
Thank you. Thank you, Dr. Farzana.
Thank you.
Santanu?
Yeah, I mean, there's nothing much to add. There's one question from Bhavita. I think maybe we can have that as the last question.
Any thoughts on why we haven't built on our frontline systems knowledge and experience with in the way that we have with the polio vaccination campaign?
Yeah, anyone? I mean, so Farzana is the only one left as the panel, so I don't want to
Yes,
the pressure
I
of
can.
answering. Yeah, please go ahead.
I can answer and you can also discuss. I think if we see our UIP or the polio vaccination campaign, it was not a one day game. Like we did not do it over one night or over one month period. It is more than 30-40 years of experience where we have reached 70%, almost 70% of routine immunization, full immunization among the children. Even regarding the polio, because I also worked in polio project. Yes, I think this is the only example in the public health how the polio vaccination campaign was like it entered each and every village of our country. The healthcare workers, right from the healthcare workers to all the stakeholders, everyone worked to like day and night to make the program successful, and there were also lots of hesitancy. So many strategies were made to address those hesitancies. So it is not an overnight program, I think, and it took lots of years to achieve that goal of our polio eradication. And for this COVID also, yes, it is as Dr. Brighu has very clearly mentioned that we did not have so much of time. We had to do everything in one go. So to roll out one vaccine in the entire country, in one go in a very short span, it's not very easy. It cannot be done very easily in this pandemic time. So I think it's not that it's as keeping in mind that our country has 3 billion population to like go to make everyone and understand about the COVID vaccine, because in rural areas, if we see still people doesn't know about the COVID. Many people said there that it is not a disease also, as some speaker has said already. So many people has even in the slums also, even if we see the maids and everyone which are coming in our houses, many have the notion that it is not something very serious or something. So it will take time roll out to the way the polio vaccination program was successful. It will also need some time.
Thank you. Yeah, hopefully we build on these lessons. I see 2 people have raised their hand. We are at 1 p.m. So I don't know, maybe what I will do is quickly ask Dr. Farzana if you have a couple of more minutes, maybe 5 because we have 2. So is that okay, like for us to go beyond? Right. So maybe if we can have Rishabh ask his question and then Sumiran. Thank you.
Thank you, Dr. Farzana. There was this ICMR released data a couple of weeks back, or maybe last week, where the severity of the percentage of people who got their first vaccine and the second vaccine was 0.03 and 0.04. And it felt, can you just sort of illuminate that? Is that data accurate? It seems too good to be true. And then there was some critique about the fact that they weren't, many hospitals weren't asking the patients whether they were actually vaccinated in the right way. There was some debate that they could trace it with the Aadhaar numbers, and just your thoughts on things like that. Like, is that data accurate in your mind?
Yeah, I think the data is accurate. There is no doubt about it, because we have the total number of vaccines, first dose of vaccines with whatever vaccines it is. We have the number of doses, at least how many doses of vaccines we have already delivered, and the first dose and the second dose, the data. But the thing is that this data, I don't think the data is still enough to say that we have vaccinated lots of people, because we still need to do like we have to go, because keeping in mind the denominator of our country, so we have to achieve, if we talk about the percentage and everything, we have to achieve at least for reaching the herd immunity, we need at least more than 50% of our population to get immunized. Other than that, so we need to and the severity of the illness and everything. Yes, it is. I think the vaccines are curtailing the severity of the disease. Those that are absolutely, these are not, because as I mentioned like few minutes back only, even in our neighbor, in our friend circle, we are seeing this, because this pandemic, this upsurge of cases have shown us that in our colleagues also, in the families of our colleagues also, we are seeing the vaccinated people are not going into the hospital, even if they're going, if they're coming back, not going to the severity of the disease and or to the ventilators. That is an obvious observation, what I have noticed, what all of us are noticing right at this moment. So I think that answers your question, Rishabh. I don't know, like.
Yes, ma'am. Thank you.
Yeah.
Thank you, Dr. Farzana, for your insight. It was very helpful, and thank you for your time. I just have a brief question. I wanted to know that during the vaccination program, did you observe any gender effect among the people who were reluctant to get vaccinated?
Oh, no, we have not, because as I already mentioned, as we are from the private provider, so no, we have not seen any gender bias like more females, because we are for whoever has come to us, maybe in the middle class or the upper middle class families, so and our own healthcare workers and our own staff and everything, we have not seen any gender bias till now. Like we are whoever has come in for the vaccination, everything. No. But if we see like the event when we talked about the AFI, and more than we have immunized more than 6,000 people in our center. So if we have done a quick analysis of our AFI cases, it is more in males rather than in females, and also in the age group of 18 to 44 years. It is very obvious increment. 96% of the AFI, whatever we have seen, it is in the age group of 18 to 44 years. Beyond 45 or beyond 60 years, people have not experienced even pain also, they have not experienced. So that was our observation.
Thank you, ma'am.
Thank you again. Big thank you to Santanu for pulling this off with us, to Anirudh and Nanditha for contributions and for all of their thought and work. To all of our speakers from this morning, thank you. There's more plenaries. Some of this was meant to be scheduled this afternoon, but now because of unforeseen circumstances, there are 2 plenaries that are now scheduled for May 7th, which is the next Friday. One of them is going to be about vulnerabilities for adolescent populations and how digital tools have been useful to create resilient support structures. The second one is about more research focused, so around the future of data platforms and how data sharing could be made more smooth as we go along. We are now on day 4th of the CoordNet conference. You can find more details on the CoordNet website and on Twitter at @CoordNet_India. And if you are a researcher and interested in being part of the community, do write to us at hello@coordnet.in. I'll also take a quick minute to add here that we are also partners of the International Growth Center. They are also part of the CoordNet community. They're hosting a conference on the 5th, 6th, and 7th. So 3 days where they share also findings and results from their studies in India, particularly Bihar, on the many impacts of the pandemic. So in case if you have time and bandwidth, just go look out for them. That's mostly all from our end. We finally again want to thank Dr. Farzana for taking out all this time and joining us for this conversation.